there a pointer in this? Okay. Respected chairpersons, my senior friends and members of the audience, I am thankful to the organizing committee for giving me this opportunity to stand before you and talk about an evolving subject in management of CKD. See, we are continuously concentrate on the management of glomerular diseases, diabetic nephropathy, hypertensive damage, etc. And we think that tubulointerstium is a bystander. It is just bears the brunt of the attack. But now the picture is changing. It is an active contributor to the progression of CKD, and how it does that and what is its role, we will just see shortly. So the renal interstitium is defined as the intertubular, extraglomerular, extravascular space of the kidney, to put it very simply. It's bounded by tubular vascular based membranes and is filled with different types of cells, extracellular matrix and interstitial fluids. It occupies a major part of the kidney. Distribution varies. Approximately 8% of the parenchymal volume of the cortex and 40% of the inner medulla. And why to talk about tubulointerstium in CKD? CKD is the burning subject today, a devastating condition reaching epidemic levels owing to the increasing prevalence of diabetes, hypertension, obesity, aging of the population. And what is the link? Regardless of the etiology, let it be diabetes, hypertension, atherosclerotic disease, etc., or glomerular disease, there is irreversible nephron loss, and that contributes. And the progression, the factors that decide include not only the cell loss, but chronic inflammation and fibrosis. And as a result of this inflammation and fibrosis, the kidney fails to regenerate in most of these situations. How does that happen? Why it happens? And what is the role of tubulointerstium? So I am not going to talk about tubulointerstitial nephritis per se, acute or chronic, drug toxins, etc. I am going to talk about the role of tubulointerstium in the currently prevalent causes of chronic kidney disease and how it contributes to progression. The normal healthy tubulointerstitial compartment with normal tubules and then the vascular structures, you can see the blood vessels seen there, and a few scattered fibrocytes and erythropoietin producing cells. The blue fibroblasts are the fibrocytes and the reddish ones which are shown in pink are the erythropoietin producing fibroblasts. These are the usual normal components. In addition, we have the pericytes and the interstitial fluid, etc. This is physiological. What happens? We will concentrate on two types of cells that are important in the process of progression of CKD. EPO-producing fibroblasts. 90% of EPO is produced by renal interstitial fibroblasts, which are called as the EPO-producing fibroblasts. 10% is extrarenal. Hypoxia is the principal stimulus for EPO expression, but this transcription of EPO from EPO-producing cells is silenced in chronically diseased kidneys. In chronic diseased kidney, there is hypoxia, but hypoxia does not stimulate EPO production. That is the drawback. That's one of the damage induced by the fibrosis of the tubulointerstium and contributes to progression of CKD. We all know about the role of anemia in causation of CKD, progression, cardiovascular morbidity, mortality, etc. And the tubulointerstitial fibrosis makes it unresponsive, the EPO-producing fibroblasts unresponsive to hypoxia. Another important cell is the circulating renin-secreting juxtaglomerular cells, which are the epithelioid appearing cells which are present in the tubulointerstium and in the juxtaglomerular apparatus, in the tubule which is close to the glomerulus. This physiologically secretes and causes activation of prorenin to renin. What happens as CKD progresses? There is a reduced response of EPO-producing fibroblasts, but there is an increased response of renin-producing fibroblasts as CKD progresses. There is also a view that maybe some of the EPO-producing fibroblasts get converted into renin-producing fibroblasts. High renin leads to the high BP values, resistant hypertension, and its contribution to CKD. These are some of the changes that happen in the normal cells of the tubulointerstitium which contribute to progressive CKD. If you see a damaged tubulointerstitium in injury from various causes, there is loss of tubules, apoptosis of the cells, necrosis of injured tubular cells, tubular atrophy, and dropout of the tubules. There is dropout of tubules, less amount of tubules are there and lot of rarefied areas. Loss of blood vessels that goes along with the tubulointerstitial injury leads to vascular rarefaction. And what happens to this lacuna left by the tubular atrophy and vascular rarefaction? It goes for fibrosis. Increase in number of fibroblasts and lymphocytes in the areas of fibrosis. What do these increased fibroblasts and lymphocytes do? We will trace it out in the near future. So the intertubular interstitium harbors other cells, which in addition to what I described earlier, the dendritic cells, macrophages, lymphocytes, endothelial cells, etc. And the important change that happens in tubular interstitium as a cause for progression of CKD is the fibrosis due to the fibroblasts, and we will have to concentrate on that. So chronic progressive kidney injury is unequivocally associated with both quantitative and qualitative changes in the interstitium, which ultimately is called as the interstitial fibrosis. The fibrotic interstitium subsequently expands at the expense of blood vessels and tubules. In normal kidneys, the relative volume taken up by the interstitium is no higher than 5 to 10%, but it occupies more than 60% of the kidney tissue in severely diseased kidney. So it cannot just simply lie there idly. It has to contribute to some damage. So what does it do? Tubulointerstitial injury not only occurs in primary tubulointerstitial diseases, but also occurs secondary to the setting of many other diseases. The common ones where the role of tubulointerstitium is being identified more and more are the diabetic kidney disease, various types of glomerulonephritis, vasculitis, hypertensive kidney injury, atherosclerotic kidney involvement, cystic kidney diseases, to name a few, but it forms a parcel of any progressive kidney disease of any etiology. That is the consensus today. So it is not just a compartmentalized glomerular injury versus tubular injury. There is always a cyclical change, vicious cycle. We start with glomerular injury, there is podocyte injury or dysfunction, severe proteinuria, lipid mediated injury, etc., and that contributes to tubular interstitial injury. Once the tubular interstitial injury happens and tubular atrophy happens and interstitial fibrosis takes place, there are atubular glomeruli. The glomeruli in course lose their vascularity and there is impaired tubular-glomerular feedback, which sets in a cascade of events that leads to progressive CKD. There is always a link between glomerular injury and tubular injury, and so we have to look at it in totality. So to know this, how much of this interstitial fibrosis and tubular atrophy is contributing to progressive CKD in our own setting, in various types of glomerular and other diseases, we did an analysis in our own center over a period of 5 years. We stopped at 2021 because we wanted to trace these patients for at least another 2 years to know how they behave, how the disease progresses. 5 biopsies were taken up for this analysis, and if you see here, we classified into 2 groups. IFTA more than 30%, what is the correlation with progression of CKD or stable? For this purpose, we took progression as more than 40% decline in eGFR or renal replacement therapy or death, stable CKD where the GFR was maintained or showed some improvement. Different categories of glomerular diseases were included in the biopsy and it was analyzed. Proliferative glomerulonephritis, about 5, severe 4 and mild 1, MPGN 1, FSGS, severe FSGS, mild FSGS, 11 number of patients. Then IgA nephropathy, severe 6, mild 1, post-transplant, severe glomerular lesions plus arterial changes in 6, arterial changes with moderate glomerular lesions 2, ABMR we did not have in this group, mild ATIN, and total of 33 cases of glomerular and post-transplant analysis, patients with biopsy, showed that when the IFTA was present in more than 30%, then the decline, the rate of progression of CKD was seen in 23 patients who showed this biopsy change. That is, it occurred in about 69% of cases, whereas 31% who were stable. I think it is an eye-opener. Instead of just looking at the primary glomerular change, severity, the scoring, etc., you have to give credit to the severity of the interstitial change also. And that is going to tilt the balance towards progress or stability. Similarly, the second group where the IFTA was less than 30% and the progression or stability was analyzed, showed that proliferative glomerulonephritis there were 6, MPGN 3, FSGS 10, IgA nephropathy 11, and MGN 17 patients. Post-transplant there were 19 plus 2, 21, and ATIN there were 4. So total number of 72 with IFTA less than 30% amongst the various classes of glomerular changes with different etiological factors. With the IFTA was 30%, surprisingly, the progression within a period of 2 years was 10% decline in GGFR, whereas 90% there was some amount of stability or it improved. It responded to the treatment for the primary condition. This was a real eye-opener. Why I did this analysis? In the Indian Society of Nephrology meeting at Chennai, Professor Adira Levin presented a paper on tubulointerstitial changes and the pathophysiology. I was asked to be the chairperson. So I did this analysis to know what is this tubulointerstitial change contributing, and this was the result. So what we have arrived at, IFTA is a final common pathway for many primary and secondary forms of kidney injury and correlates with progressive kidney damage. In human CKD, prominent inflammatory infiltrates in the interstitial compartment and the tubular cells as well as the macrophages contribute to the extent of these infiltrates. The number of fibroblasts present and the degree of fibrosis correlate with the progressive decline in kidney function. So in this tubulointerstitium as a cause of progressive CKD, 3 things stand prominent. 1, the changes that happen in the proximal tubular epithelial cells. 2, the severity of fibrosis that is induced, that is due to transition to myofibroblasts. The third factor is the infiltration by cells of inflammation from outside, the macrophages, the lymphocytes, etc., how it happens and how it contributes to progression. If you look at the cells of the tubules and the interstitium, the juxtaglomerular cells produce renin, macrophages are present in the tubules, tubular cells, the epithelial cells, and the endothelial cells. How they undergo transition? The macrophages promote inflammation and tissue damage through protease production. They are part of the milieu of the tubules. They also come from outside, but they contribute to inflammation. And the tubular cells, the epithelial cells, de-differentiate to recruit inflammatory cells and activated fibroblasts. This conversion of epithelial cells to fibroblasts is called as the epithelial fibroblast transformation or epithelial to mesenchymal transformation, EMT. This is a very important step in the progression of damage leading on to interstitial fibrosis and initiation of inflammation. The endothelial cells accelerate hypoxia and produce ischemic changes in the tubules and interstitial cells and contribute to initiation, progression and perpetuation of inflammation and fibrosis. The role of tubulointerstitium. So we will take diabetic nephropathy as an example where what is the role of tubulointerstitium? Glomerular sclerosis is a cardinal feature. The renal proximal tubular epithelial cells play an important part. The PTEC, proximal tubular epithelial cells, are indicted in abnormal protein trafficking through the glomerulus. Progression to CKD is characterized by several pathogenic mechanisms converge upon a common pathway leading to progressive interstitial fibrosis. What is the role of this PTEC, proximal tubular epithelial cells? By handling excess glucose and by reabsorbing lot of glucose through SGLT, the tubular cells have a work to do, extra work, So that leads to hypertrophy of these cells, enhanced tubular growth related to glucose reabsorption, proximal hyperreabsorption, and diabetic milieu thus induces early tubular cell proliferation. And this different substrates like glucose, advanced glycation end products, protein leak, etc., in the proximal tubular epithelial cell, which is at the center, leads to certain pathophysiological mechanisms called cell cycle arrest, cell hypertrophy, and senescence in the tubular cells, upgraded inflammatory cytokine and chemokines in the tubulointerstitium, profibrotic cytokines, epithelial to mesenchymal transmissions, extracellular matrix formation proteins, and epithelial myofibroblast transformation. That is the key word, that is the key change that keeps on happening to induce interstitial fibrosis. So in addition to inflammation, the important steps in the progression are interstitial fibrosis, then recruitment of macrophages into the matrix, and they cause a lot of releasing growth factors, the important one being transforming growth factor beta, which remains an important stimulus or cytokine for renal fibrogenesis, ultimately leading on to epithelial myofibroblast transdifferentiation, EMT, which happens initiated by the proximal tubular epithelial cells. It ultimately results in tubular cell hypertrophy, release of antigenic substances, and in interstitial fibrosis also. Just dwell upon this with these cartoons for a few seconds. If you look at the tubular cells at the top, as they undergo degeneration, they undergo phenotypic changes in their morphology, and the cells get arrested at different stages of growth. In addition, there is tubular basement membrane disruption. The matrix metalloproteinase, which is released there, causes this TBM disruption, and that leads to partial EMT, that is, changes from epithelial mesenchymal transformation, and with that there is release of these fibroblasts, the bluish ones which are the fibroblasts. They enter into the interstitium and they lead on to myofibroblast formation and fibrosis. So this is typically seen in AKI to CKD transition. Epithelial cells undergo phenotypic changes, epithelial mesenchymal transition, tubular basement membrane disruption, and myofibroblasts are formed, and they lead on to collagen producing cells, result in fibrosis and damage to the tubulointerstitium. Just look at the infiltrating macrophages, which are the important players in this playground. Macrophage phenotype, when there is inflammation and it resolves, we see here the macrophages undergo transition to M2 level, and this M2C macrophages help in repair. They help to reduce the injury. They keep the process under check, but that is up to a certain level due to TGF-beta activation. When it crosses that limit, unresolved inflammation, when the inflammation keeps on continuing, that gets the macrophages to get converted to the MMT cells, the macrophage mesenchymal transition, and the still ongoing damage and stress that gets converted to myofibroblasts. That's the role played by the macrophages, because a lot of literature on macrophages, interstitial fibrosis, and progressive renal damage. Suffice it to say, M2 formation from macrophage, physiological, helps in repair. When M2 goes beyond control and becomes MMT, then it leads to myofibroblast and proliferation. So, I will have a few more slides, just 3 slides. These data highlight that proteinuria, interstitial inflammation, fibrosis is a contribution for progressive renal damage. And last 10 years, research aimed at identifying therapeutic agents. So what's the purpose of all this research? We have to identify some measures or drugs that will arrest this process of progressive tubulointerstitial fibrosis, macrophage infiltration, and changes induced by the tubular epithelial cells, transition of epithelium to mesenchymal, and then the mesenchymal to myofibroblast transition. The important ones that have been identified are the genes dealing with inflammation and certain epigenetic mechanisms. But this is under research. Gene sets linked to this progressive are some genes which are associated with upregulation of inflammatory genes. Another factor, the NRF2, is a protective mechanism in this process, and now steps are underway to stimulate this NRF2 activity so that we can protect the tubulointerstitium and prevent further progressive damage. This is for the future, but now we have some evidence on what is happening and what are the observations. Thank you.